Today we are going to study about eyelids. So this is the applied anatomy and physiology of eyelids. The eyelid is composed of various layers that can be divided into two layers. On the lid margin, anterior and posterior lamellae are demarcated by a gray line, which is surgical plane to separate the two lamellae during eyelid surgery. Okay, now let's talk about the anterior lamellae. What does it include? It includes something called SCSS. So the skin is the thinnest and transparent skin of the body. It has fine hair, sebaceous glands, and sweat glands. Then there's something that starts with a C. So subcutaneous connective tissue. It is a loose connective tissue which has no fat. Then there is the striated muscular layer. It is the palpebral part of the orbicularis oculi muscle. And then we have after the muscular layer, we have submuscular connective tissue, which is present between the O and T, which is orbicularis and tarsal plate. It has blood vessels and nerves. So the submuscular connective tissue is also vascular. Now for the posterior lamellae, so the mnemonic is this. So the fibrous layer has a thickened central part called the tarsal plate, and a thinned palpebral part is there, which is called the palpebral fascia. Now let's talk about this diagram. So first of all, we can see these are the glands of Krause, and this is a meibomian gland which is present in the posterior lamellae. I've also made this diagram anyway. Okay, now for the levator muscle aponeurosis, which is the second part of the posterior lamellae. Okay, it has a fleshy muscular part which lies in the orbit, and the membranous aponeurosis lies in the upper eyelid, whose expansions are attached to the skin, tarsal plate, canthal tendons, and upper fornical conjunctiva. Now for the non-striated muscle, which is a Muller's muscle. It is going to come in many things afterwards, so please remember this. It lies deep in the palpebral fascia, in the upper eyelid, and in the lower eyelid. We're going to say some things, okay? So in the upper eyelid, it arises from L and T. So it arises from levator tendon, and it is inserted into the upper border of the tarsus. Upper border of the upper tarsus. And in the lower eyelid, it comes from the capsulopalpebral head of inferior rectus muscle, and it is inserted into the lower border of the tarsus muscle. Then comes the membranous layer. It is vascular, it is thin, transparent, and adherent to the tarsal plate. Okay, so this is the tarsal plate. Now let's talk about lid margin. Eyelashes are arranged in 2 or 3 rows and lie anterior to the gray line. So this is the meibomian gland orifice, and this is the conjunctiva. Here we can see the conjunctiva, and this is the tarsus with meibomian gland. Lamella, this entire is the anterior lamella. This is the gray line, and this is the posterior lamella. And here we can see the orbicularis oculi muscle. In the lid margin, after the eyelashes, we also have zeis and glands of mole. So orifices of meibomian glands are going to lie posterior to the gray line. Okay. So now let's talk about the glands of the eyelid. अच्छा, जो स्किन होती है उसमें sebaceous glands होते हैं and sweat glands होते हैं. जो tarsal plate है, meibomian glands होते हैं उसमें 30 to 40 in the upper and 20 to 30 in the lower plate. They open in the eyelid margin and they produce only secretion for tear film. And then we have the lid margin, उसमें glands of zeis होते हैं. They are modified sebaceous glands which are attached to the lash follicle. Then we have the glands of mole, which are sweat glands, which lie obliquely in contact with the bulb of an eyelash. Okay, so lid margin में glands of zeis होते हैं. So remember Zeus for that, modified sebaceous glands, okay? Okay, now for the blood supply, it is very easy. Lid is supplied by the medial and palpebral branches of the lacrimal artery and the ophthalmic artery. Now for the lymphatic drainage, it is going to drain into the preocular, preauricular, and the submandibular lymph nodes. Now the nerve supply. So of course you remember LR6SO4O3, which is the mnemonic for the nerve supplies. Now for the motor supplies, we are going to remember that. Achha, so here we can see that this eye is open and 3 is written on it. So oculomotor nerve supplies the levator muscle because the eye is open, and the facial nerve is going to supply the orbicularis oculi muscle, which helps in closing the eyelid since this eye is closed here, and sympathetic nerves will supply the Muller's muscle, which lie deep in the palpebral fascia. Now for the sensory supply, it is supplied by trigeminal nerve through ophthalmic and maxillary division. So upper eyelid is supplied by supratrochlear nerve, supraorbital nerve, lacrimal nerve, and infratrochlear nerve. So infratrochlear nerve is going to supply both the upper and lower eyelids, okay? And same goes for the lacrimal nerve. So lower eyelid is supplied by infratrochlear nerve, lacrimal nerve, and also the intraorbital nerve, okay? Then the functions of the eyelids: mechanical protection from external injuries and stimuli, and maintenance of tear film is by distribution of tears by eyelid movement, support to tear film by lower eyelid margin, and by oily secretion of the meibomian gland, it prevents the drying of the tear film. Now let's talk about a condition called trichiasis. It is basically the misdirection of growth of eyelashes towards the globe. So it is caused by chronic blepharitis, which is basically an inflammation of the eyelid margins. And it can also be caused by chronic conjunctivitis, as in trachoma, and it can also be caused by autoimmune conditions like Stevens-Johnson's syndrome and OCP, which is ocular cicatricial pemphigoid, and chemical burns and eyelid margin injuries. Okay. Then clinical features are that, okay, these ones are lacrimation, photophobia, foreign body sensation due to the misdirected lashes which are rubbing the cornea, here you can see, and also conjunctival redness and corneal epithelial defect and corneal ulcerations and secondary infections. This is the important one. Then for the complications, we have conjunctivitis, keratitis, and corneal opacity. Now, how to treat this? First of all, we can treat this with epilation. So we can use a forceps to remove lash follicles mechanically, or we can also use we can also destroy the eyelashes instead of epilating them. So this can happen through argon laser, cryoablation, as in freezing, and electrolysis. So in electrolysis, lash follicle is destroyed by electric current through the fine needle inserted into the root of the lash. And in argon laser, lash follicles are destroyed by laser. It is a simple procedure that causes accurate destruction of the lash. Then we have cryoablation. So we destroy the lash follicles here by freezing the follicles at -80 to -90 degrees centigrade with special cryo probe. It is effective in eliminating a large number of lashes simultaneously. Then for the contact lenses, which are used to protect the corneal damage caused by rubbing of eyelashes, it is a temporary measure. And for the surgery, so we do wedge resection surgery when trichiasis is confined to a segment of the eyelid. Then we can also do anterior displacement of the posterior lamella of the lid, and then differential diagnosis. Distichiasis is a congenital abnormal condition. So here you can see distichiasis, where additional row of lashes is often directed backwards and it irritates the conjunctiva and the cornea. Okay, and there's also something called pseudotrichiasis or marginal entropion. It is a misdirection of eyelashes secondary to the entropion. The clinical features are same as trichiasis, but symptoms are more severe. Treatment is correction of entropion by surgery.